when I was asked to give this talk, David actually asked me to give a provocative talk. So this talk is going to be a little deliberately provocative, but I've identified some key questions which I think are very real in this issue of vaccination and the drive for vaccination and what it actually means. So these questions are: is eradication possible? And this applies primarily to COVID. Is antibody-dependent enhancement likely? Are vaccines safe for kids? Is vaccine equity insoluble? Are mandates necessary? And what is the purpose of vaccination then? And I hope to give you my version of the answers to these questions in the end of this half hour. So first off, you hear different views from scientists in different parts of the world, and that sometimes upsets the public because they say, how come scientists can't agree? Surely science has got one answer. And the answer is science does not have one answer. And in fact, one of the most successful vaccination programs has been the polio vaccination programs. And as you know, there were two different polio vaccines. And the two scientists who derived these vaccines, Salk and Sabin, they essentially hated each other. From what I've heard, one would say black is white and the other would say white is black. But yet, in spite of that, the vaccine program proceeded, and we're now in a very happy state as far as polio is concerned. The older ones amongst you will recognize this. This was Kallang Airport in 1958, and people in Singapore were thronging the place to get vaccinated against polio. And the reason for that was in the end of 1958, Singapore experienced an outbreak of type 1 polio. So this was picked up by Ministry of Health, and the decision was made to try and get hold of the type 2 polio vaccine. So interestingly enough, they used a heterologous strain for the vaccination, and this was driven by Professor Montero. He wrote to Dr. Sabin, who agreed to release this vaccine, provided there could be adequate biosafety levels of protection. Interestingly enough, Dr. Frida Paul, who is also a professor of pediatrics, she predicted this outbreak with the decline in infant mortality. Because again, polio, as you know, in young infants used to cause a mild disease, but in the older infants in cleaner countries, you could see a rise in cases. And true enough, this is what happened in Singapore. So anyway, the campaign was hugely successful. Polio essentially disappeared from Singapore. We have very high vaccine coverage for polio. And now in line with the WHO, we have stopped giving polio type 2 vaccine. And now we give a bivalent polio vaccine, which only covers type 1 and type 3. Type 2 polio is considered eradicated. This is from the WHO, where a polio eradication program, where as you can see, wild-type poliovirus type 1 is only circulating in one area in the Afghan and Pakistan border, in the highlands and the Himalayas. You've got circulating vaccine-derived polio type 1 in Madagascar and in Yemen. And then you've got circulating vaccine-derived type 2 polio in various other settings reported earlier this year. So how do we know that this data is accurate? There are two surveillance mechanisms that the WHO uses. The first is acute flaccid paralysis surveillance. So they want to make sure that they pick up every single case. So cases of Guillain-Barré, you must have a certain level of Guillain-Barré within your population, and then a certain proportion of these must be tested so that we know that we're not missing cases of polio. And the second, which is interesting because it's used a lot in this pandemic, is wastewater surveillance, which has been highly effective at picking up circulating vaccine-derived polio in many parts of the world. So Singapore, essentially polio disappeared from the mid-1970s following the highly successful clinical trial of the type 2 vaccine in 1958, the rollout of trivalent vaccination, very high immunization coverage, and essentially disappearance of polio. In 1999, there was a case in a 4-month-old who was a bit too young for vaccination. I don't know whether any of you were involved in the care of this child. It was after his first dose of OPV, and he had Sabin-like vaccine-derived polio type 1 in his stool, but he recovered completely and was decided not to be classified as a case of poliomyelitis. There was an imported case of wild-type poliovirus in 2006 in someone coming in from Nigeria, but essentially we have been polio-free for more than 2 decades. So again, there's continued risk of wild-type poliovirus spread, mainly from Afghanistan and Pakistan. But circulating vaccine-derived polio is the one which has been a concern. China has picked it up through wastewater surveillance in many parts of the country, and they've also picked up type 1 polio, presumably vaccine-derived polio as well. So the 28th IHR Committee for Polio, which met in May of 2021, gave this stunning report. Wild-type poliovirus 1, countries that were no longer infected but remain vulnerable, none. So they're well on track to eradicate a second poliovirus after the eradication of poliovirus 2. Circulating vaccine-derived polio, there are certain countries which are still susceptible. So how are they proposing to do this? They actually came up with this proposal, which is also interesting in the light of what we hear about COVID, the idea of vaccine travel regulations. Because currently the comment was that yellow fever is the only disease mentioned in the IHR for which countries can require proof of vaccination. But following the advice of the Polio IHR Committee, they issued temporary recommendations allowing certain affected countries to require proof of polio vaccination for international travelers. Closer to home, in the middle of the pandemic, actually, Malaysia reported 4 cases of polio, vaccine-derived poliovirus type 2 in Sabah in individuals who were believed to be connected with Filipino migrant families, and 25 environmental samples picked up from wastewater surveillance. So they launched a massive vaccination program, which managed to keep that under control, even in the midst of the pandemic. The pandemic has had an impact not just in Sabah, but even in Singapore, where colleagues have reported drops in actual routine childhood immunization, which hopefully is picked up in a post-circuit breaker. So polio is on the verge of eradication. One of the areas of concern has been immunodeficiency-derived vaccine-derived polio. And again, this is something which has caused morbidity and mortality in children with immunodeficiencies, as well as this concern about facility-associated release of polio or laboratory-acquired polio, which can actually be associated with cases outside of the laboratory, which has been reported a couple of times in the last 2 decades. So many of you who do work on viral cultures will know that MOH sends out these circulars asking us for whether there are any samples which could potentially be contaminated with poliovirus, and these are very tightly regulated. So it's back to the question of COVID. Is eradication possible? Now, polio has only got one host, the human. So it's relatively easy to do. As you know, the lions in the Singapore Zoo, now we're up to 5 who are infected. And there's a whole range of animals who can be infected with COVID, including the minks who have been infected. So you've got human to mink, and then mink to back to human. So I don't think it's possible to eradicate COVID-19. But in spite of this, there's at least one big country which is still going for a zero COVID strategy. And I think part of the reason for that is the lesson or the memory of SARS. Now, you'll remember that SARS first appeared in November 2002. The global alert was issued by the WHO on the 12th of March after a registrar from Singapore who was attending a board review course in New York was diagnosed clinically with SARS. And within 2 months, essentially the SARS outbreak was brought under control, and the last case of naturally occurring SARS occurred in July. We had a laboratory case in September. And then in January of 2004, there was a handful of cases in Guangdong in China. So when we had SARS-CoV-2, a lot of us in many parts of the world went for SARS-CoV eradication or zero COVID. But there are big differences. Number one, SARS did not affect the vast majority of countries all over the world. It was mainly concentrated in countries in East Asia and North America. Number two, we knew the proximal animal within 2 months of the WHO global alert. So in 2004, once there were cases identified in Guangdong, it was relatively easy to find the restaurant which had civet cats, to get rid of the civet cats and to stop the outbreak, so you didn't get SARS 2004. So in terms of COVID eradication, I think it's extremely unlikely. Zero COVID strategies, I think, are doomed to fail. What about antibody-dependent enhancement? Now, antibody-dependent enhancement has been anticipated for COVID. It may not necessarily be in the form of non-neutralizing antibodies, which we're familiar with the dengue virus, but potentially with immune complex formation through macrophages which ingest the virus. And I'm not an immunologist, so I'm not going to pretend to be able to explain this fully. But we do know that immunopathogenesis has been a concern. The most successful drug in the treatment of COVID has been dexamethasone. We've also been using baricitinib and a number of immune modulatory agents. Now, again, we remember the first licensed dengue vaccine. In its initial publication, when they studied the vaccine efficacy, it was highly effective against most of the serotypes, less effective against serotype 2. It was effective in individuals who are both seropositive and seronegative at baseline. It was more effective in those over 9 years of age, not so effective in the under 9 years of age, and it was launched to a great deal of fanfare. However, in the 5-year follow-up study, which was published in the New England Journal of Medicine, all of a sudden you saw a dichotomy between those who are seropositive at baseline, in whom the vaccine remained highly effective, and those who are seronegative at baseline, in which case the vaccinees actually had a higher rate of hospitalization and severe disease compared with those who received placebo. And so in a way, this was validation of the concept of antibody-dependent enhancement for dengue vaccines. And again, the vaccine is, as I understand it, not doing very well. So there have been a number of previous corona vaccines that were studied in animal models, including mice and primates, ferrets, and antibody-dependent enhancement was, immune enhancement rather, not necessarily just antibodies, was a concern. But again, this has not appeared with any of the licensed COVID-19 vaccines to date, but it's possible that it may just be too early. For the dengue vaccine, our HSA put out a very comprehensive risk management plan, which included mandatory reporting of all AEs, submission of significant AEs, and I think most importantly, they put out a criteria for who should actually receive the vaccine in mandating seropositivity testing. So is ADE likely? Maybe. I hope not. It's still too early to tell. The next question that comes up is, are the vaccines safe for kids? Now, this has been an issue because COVID has affected primarily the elderly, and it has significantly spared the young. As you can see this from the global data from the Johns Hopkins group, the mortality rate in many countries for children is actually below the all-cause mortality rate now compared to early on in the pandemic. In comparison with adults, there's significant excess mortality, especially last year in the spring in the Northern Hemisphere, and it's starting to go up in some parts of the world as well with this winter. So the concern has been with various adverse events. The most prominent has been myocarditis in young men, which has seen a significant rise even in the early studies in Israel looking at the rollout of the vaccine, where the rates are much, much higher than in females and in those of an older age group. A group of us wrote a paper which is out in Journal of Adolescent Health trying to compare this. And while the United States, Israel, and Singapore have rolled out COVID vaccine in adolescents, other countries have been a little bit more cautious and they have concentrated on the most vulnerable. The UK, for example, on those who are immunosuppressed with severe neurodisabilities, those with long-term serious conditions. The FDA initially was hesitant to approve the vaccines for those children, but as you all know, in the last week or so, they published the risk versus benefit calculation, and this is freely available on the FDA website, where they nicely illustrate that at the time in September of 2021, the number of cases of COVID that would have been prevented in terms of hospitalizations outweighed for the 5 to 11-year-old males was 67 versus 57 cases of hospitalization due to myocarditis. So a slight benefit to ICU stays and to hospitalizations. Hospitalizations 203 versus 150. However, if the incidence of COVID were to drop to a scenario where the COVID cases were 5% of what they were in September of 2021, then you would have 7 cases of ICU COVID that were prevented with vaccination versus 57 cases of ICU myocarditis. So they're in the younger males. So the risk versus benefit depends significantly for the child. Actually, it depends on the prevalence in the population as a whole. There's also this issue of whether you vaccinate the children to protect the adults, which works very well for influenza. And the concern, though, is that children may not actually be a reservoir for transmission. And we did a small study which seemed to suggest that. Now, the counter to that is people are saying, oh, these vaccines are really dangerous in children, they're new vaccines, etc. And, I turn around and say all vaccines have risks in children. And in fact, Singapore has very good vaccine adverse event monitoring. HSA publishes a bulletin every year where they report on them. And we have probably among the world's highest rates of vaccine adverse event reports. And that's purely because our pharmacists are really on the ball. And HSA is actually proactive. They work with KK in picking up pediatric hospital administrations for adverse events post-vaccination. So this is in 2020, and what they've reported is they've reported Kawasaki disease, meningitis, intussusception rotavirus vaccine, and all kinds of side effects with the licensed vaccines that most people don't seem to have any problem with. What is intriguing about these adverse events, though, is the cause of these adverse events, because these are rare. Even myocarditis, the highest incidence is 1 in 10,000. What that means is 9,900 young men do not get myocarditis, but 1 in 10,000 does. So the question is why? So some of you may remember the H1N1 pandemic of 2009. With the GSK vaccine, there was an increase in narcolepsy. So a group of scientists actually worked on this. And what they identified was there was an HLA strong link between an HLA DQB positivity and this particular vaccine and its adjuvant. It wasn't seen with the other vaccines. So I think that's what we need to do. We need to differentiate between the different vaccines and carefully identify who are the ones at risk. There's also a perspective. This is a figure which is cited a lot in those people who talk about risk in children. In Singapore, every year, there are close to 50 to 100 children who die from drowning in swimming pools. And these studies are done by the Lifesavers group, by the A&E groups. And the point is that we don't stop children going into swimming pools. We just try and make it a lot safer. So just because vaccines have got adverse events or diseases have got adverse events, it doesn't mean we stop finding a way to make them safer for everyone. The next question is on vaccine equity. Now, this is a huge issue. This is from the WHO Independent Panel report published in April. And what they showed was some countries like Canada have enough vaccine to vaccinate every Canadian 5 times. UK about 3.5 times, New Zealand about 3.5 times. By now, it's about 10 times. Every Canadian can get 10 doses of vaccine. In contrast, you've got people in Kazakhstan, you've got people in Jordan, in many parts of sub-Saharan Africa who can't even get a single dose of vaccine. And this has been the case with seasonal influenza vaccines for a very long time. This chart shows GDP on one side and seasonal influenza vaccine per 1,000 population on the other side. And it's almost equivalent. There are a couple of outliers. Singapore, high GDP, low flu vaccination coverage, similar to Brunei and the UAE. So why are vaccines so expensive? People say it takes a lot of money to develop. Actually, it takes more than just the development. This is in the last pandemic. I got invited to this influenza expert meeting at the Hilton in the Heathrow airport. They would fly me in, fly me out, give a nice dinner. And that, I'm sure, contributes to the cost of the vaccine. But the big cost is not just the KOLs, it's the patents. And this was an issue that was brought up during the last pandemic, H1N1 2009, by the governments of Argentina and Brazil. And there was a lot of pushback from high-income countries. And this comes back to the HIV generic drug argument. And this was the US senators where they wrote into the US trade representative arguing that strong protection for intellectual property is critical for America's economy. Thailand's action to compulsory license the drugs they said was going to kill US-based research industry supporting more than 2 million workers, and it could have harmful consequences for patients. Of course, you know that soon after that, there was this anthrax outbreak in Capitol Hill. So anthrax was prophylaxed with the use of ciprofloxacin. but the Bayer couldn't make enough ciprofloxacin for the US population. And so the US government, guess what they did? They threatened to compulsorily license ciprofloxacin to make it for, to waive the patent until Bayer agreed to supply 100 million pills to the United States for almost half the price. So all of a sudden, the issue of patents become less important when you've got somebody close to home. The other issue that's raised is whether developing countries have the capacity to manufacture vaccines. And the reality is most of the UNICEF vaccines are actually manufactured in middle-income countries, primarily in India. And this is not new. Way back in the smallpox eradication campaign, vaccines were manufactured in Indonesia, in many parts of sub-Saharan Africa and Latin America, and they met WHO quality control. So this issue has been raised at the WTO by Médecins Sans Frontières, and in fact, even the independent panel report reviewing the WHO has pointed out that this is something that companies have to be prepared for. These TRIPS waivers say you can make the vaccine, you can make profits in high-income countries, but you've got to make sure that people in low and middle-income countries have access to them. So it's a win-win situation in a way. And this was raised early on during the H5N1 situation when Indonesia, who provided samples to the WHO collaborating centers, all of a sudden found out that these samples were given to companies which went on to try and sell the vaccine to Indonesia. And this led to this formation of GISAID, which is a tremendous resource all over the world for sharing of viral sequences. Now, can this work in COVID? And I think it can. You look what's happened in the last week. We've seen that molnupiravir is actually being manufactured in Bangladesh and dispensed and given out through the global patent pool. So if it already works for an antiviral, I think it's really hard to understand why it's not working for vaccines. So is vaccine inequity inevitable? Definitely not. Next question, are mandates necessary? Now, mandates have come in across the world, and I just heard in Austria and Germany, they're trying to do lockdowns for the unvaccinated. Singapore is not quite as bad as that. And part of the reason is because the vaccines do work very well in adults. So this is data from MOH from the end of last month. You can see that the unvaccinated have about 10 times the rate of death compared to the fully vaccinated. And this is at all age groups, but especially so in the over 80s. However, the problem is the vaccines are not that great at preventing transmission, and this is work done from NCID with the MOH contact tracing data. If you are vaccinated, you're less likely to get infected if you have a contact who has COVID. But on the other hand, if you are unvaccinated and you're the index case, your risk of transmitting the virus to those around you is the same, whether you're vaccinated, unvaccinated, or partially vaccinated. And there's a paper that's just come out in Science Immunology about this, which again, I'm not going to pretend that I understand and try and explain. So I think this raises a concern. You see, you're asking people to be vaccinated to protect themselves, but not to protect necessarily to protect other people. With the polio vaccine, there were people flocking to get vaccinated because it was obviously effective. We haven't reached 100% coverage, but it's been good enough. We've been 95 to 97%, and we've essentially eradicated polio for the last 20 years. So the question is, can we mandate a vaccine which doesn't significantly prevent transmission? Another way of looking at it is looking at the other mandated vaccines. As you know, there are only two other mandated vaccines in Singapore, diphtheria and measles. So measles was mandated for school entry. But in spite of that, before the pandemic, we had a spike in the number of measles cases. These were primarily in people in a disability home and a migrant worker dormitory where they may not have been fully vaccinated. In fact, if you look at the data on vaccination in Singapore, the measles vaccination rate, despite the mandate, is only about 88 to 89%, which I find really odd. And I'm trying to understand why. It's whether people are getting out of school or they're finding some way of getting exemptions. But in spite of that, we are making good progress towards the elimination of measles. The vast majority of measles cases in Singapore that have been reported by MOH have been in individuals who have not completely been vaccinated. There's really a tiny number of so-called vaccine breakthrough cases with 2 doses of MMR, about 1 to 2 cases a year. So this question is mandates. Do they work? Do they not work? And there's scientists, again, who disagree all the time, maybe not as bad as Sabin and Salk. but during the time of the post 9/11, the smallpox vaccination campaign that was rolled out for healthcare workers, two of the doctors I respect the most, Fred Hayden from the University of Virginia and Richard Wenzel from Virginia Commonwealth University, diametrically opposed views on the topic. But ultimately, one of them turns out to be right, but it takes some time. So don't get me wrong, I'm not against vaccination. I was vaccinated against the Pfizer-BioNTech vaccine, mainly because I want to travel. You know, it's been like deja vu coming to this meeting in person. I'm a healthcare worker. I want to make sure I protect my patients, and I want the pandemic to end. This is me with the director of the Mongolia CDC at the Genghis Khan statue. So finally, I think we vaccinate so that we can stop vaccination. This picture was taken last night by my wife of my arm, and I'm one of the few people in Singapore with 2 doses of smallpox vaccine. I had a smallpox vaccine when I was a kid, and then my dad went on his HMDP to Australia in 1970, and at that time, Australia was smallpox free, Singapore was not. So I had to get a booster dose of smallpox vaccine. But smallpox is gone, we don't vaccinate anymore. We stopped vaccinating against poliovirus too. And there's a matter of time before we're going to stop vaccinating against measles, because that will go too. But ultimately, this is my favorite slide, which I show to medical students and every time I get a chance. It's actually the incidence of infectious disease in the 20th century. And what you can see is there was a steady decline with the flu pandemic of 1918, small rise with HIV. But the decline occurred long before the first use of antibiotics or the widespread use of vaccines. And it was primarily due to chlorination of water and better housing, which brought down the tuberculosis rates. So I tell the medical students, it's actually not the doctors who save the lives of people from infectious disease, it's the engineers. So we really don't want to be in a situation where Changi Airport is deserted like this. Hopefully that will not happen with the next pandemic. If you have any other questions, please feel free to email me. Thank you.
Paul, thankfully, there's nothing on my
Even not from
tablet.
Julian.
But I have one question for
Sure.
you just to close this session. What do you think of the government's initiative to link the licensing of clinics with the fact that they wanted the healthcare worker to be completely vaccinated with MMR and Tdap?
Yeah, I mean, I think I see where they're coming from. There are 2 reasons there. First reason is obviously to protect the patients,
Yes.
because the clinics are going to see immunocompromised patients. And immunocompromised patients are at very high risk. We've seen severe measles in immunocompromised individuals. And a lot of the clinics have workers who come from overseas, where the initial vaccination may not be complete. So I think it is reasonable, but they need to be sensitive to those who cannot be vaccinated. Those who do not want to be vaccinated, they have a choice. They can go somewhere else. You can do something different. But those who cannot be vaccinated, I think we need to be a bit sensitive to them.
So I think that they also realize with measles, there's an immunity gap in those that are in the 30s to the 40s. So if you don't vaccinate them, then outbreaks can occur,
That's
even
right.
if it is in an adult hospital.
Yeah, those our age, we all got measles as kids.
Right.
Natural immunity.
Okay. Thank you for that marvelous talk.
Thank you.